Welcome to This Explainer. Today, we're diving straight into a fascinating medical mystery. We're going to figure out why a standard everyday C-section can sometimes lead to a lifetime of complications, and more importantly, how we can physically build a better scar. I'm your host, and we are going to unpack the hidden engineering behind uterine healing and long-term maternal health. Right off the bat, we have to ask a pretty critical question. Why does a routine surgery, literally one of the most commonly performed procedures on the planet, leave up to 35% of women dealing with severe long-term issues long after they've left the hospital? It's a staggering reality, and honestly, it's something that just isn't talked about nearly enough. And the stakes here? They are incredibly high. We're talking about 24 to 46% of patients experiencing abdominal adhesions after a C-section. And what's truly alarming about that is these adhesions actually get worse with every subsequent surgery. So we aren't just talking about a minor surgical inconvenience, we are talking about maternal health on a massive, systemic, long-term level. To solve this, we're mapping out an architectural investigation of the uterus. We'll cover the hidden complications, clues from animal studies, the tissue strangulation problem, locked versus unlocked sutures, optimizing suture direction, and finally, a definitive 3-step solution. Okay, Section 1. The hidden complications. Let's look at the long-term effects of C-sections. You see, impaired uterine healing isn't just about a superficial scar on the surface. It is directly linked to chronic pelvic pain in 11 to 35% of cases. There's also postmenstrual spotting and even secondary infertility, affecting up to 13% of patients. These complications essentially show us that a poorly healed uterine scar acts like a trapdoor to chronic pain, delayed conception, and highly dangerous placental abnormalities in future pregnancies. Moving on to Section 2. Clues from animal studies. Uncovering the villain of scar healing. To figure out what's going wrong, researchers actually looked back at nearly a century of animal studies, from guinea pigs back in 1925 to cats and rabbits in '61, all the way up to 2020 mouse models. And all this historical data points to one singular villain: endometrial inclusion. This happens when the inner lining of the uterus, the endometrium, accidentally gets trapped inside the surgical scar during stitching. When those cells get buried deep in the muscular uterine wall, it completely disrupts the structural integrity of the healing tissue. It essentially sabotages the repair process from the inside out. Which brings us to Section 3, the tissue strangulation problem, the engineering flaws of closure. Think of the tissue layers as building materials. In a single-layer closure, if a surgeon grabs way too much tissue all at once to close the wound, it creates immense uneven tension. You are severely mishandling the materials. This physically strangulates the cells. It causes ischemia, which is a severe lack of blood flow and oxygen to the tissue, and creates a massive structural weakness in the uterine wall. You're effectively choking the very tissues trying to heal, and that leads directly to those exact defects and complications we just talked about. Next up, Section 4, locked versus unlocked sutures. Let's analyze those building materials. When we compare the actual mechanics of these closures side by side, the data tells us something really interesting. While locking a suture isn't completely harmful on its own, it significantly impairs microcirculation when it's pulled under high tension. It basically acts like a tight zip tie clamped down on incredibly delicate tissue. Breaking down the clinical comparison, the data clearly points to unlocked double-layer continuous sutures as the superior method. It produces a thicker, much healthier residual myometrium and allows for precise apposition. In plain terms, it brings the tissue edges together perfectly without cutting off that crucial blood supply. And this is especially vital when making sure that the inner endometrium is entirely excluded from that first layer of stitching. Let's move to Section 5, optimizing suture direction. Aligning the architecture. I absolutely love this quote from the research. It notes that parallel placement produced greater bursting strength, less inflammation, and less tissue necrosis. Why? Because the tension is distributed along the wound axis. Experimental evidence shows us that aligning sutures parallel to the incision distributes that tension perfectly evenly. When sutures are pulled perpendicularly, they can essentially act like a wire cutting through cheese, severely damaging the delicate uterine tissue. But parallel placement? It prevents that entirely. A great example of this is the purse string double-layer closure technique, where sutures are oriented parallel to the incision. Rather than securing tight knots at the very ends, the suture is run circumferentially and then tightened centrally. This parallel orientation reduces focal ischemia, avoids that awful cheese wiring effect, and creates a dramatically stronger, much more functional scar. Finally, Section 6, the three-step solution, the optimal architectural fix. Everything we've discussed boils down to this meticulous three-step solution. Step 1. Expertly handle the endometrium by bringing the junction together while completely excluding the interdecidual surface so it never, ever gets trapped. Step 2. Perfectly restore the myometrium wall without grabbing too much tissue and strangulating it, effectively minimizing dead space. And Step 3. Protect the serosa, which is the uterus's outermost layer, ensuring coverage of exposed tissue to optimize hemostasis, or the stopping of blood flow. By following this precise rule of layers, surgeons ensure they don't bury the first layer, totally optimizing the healing environment. When it's done right, a perfectly restored uterine wall is just a beautiful piece of biological engineering. By applying these exact techniques, excluding the endometrium, using unlocked parallel sutures, and protecting the outer serosa, surgeons can drastically minimize the structural defects responsible for those devastating long-term hidden complications we talked about at the very beginning of this explainer. So, as we wrap up today, I want to leave you with a provocative thought. We now know the mechanics. We know the biological villain. We literally have the architectural blueprint for success. So if precise tissue apposition directly dictates long-term maternal health, how quickly can this three-step approach become the new global standard? Think about the millions of women whose lifelong health and future families depend on the answer to that question. Thanks so much for joining me, and keep exploring the science behind the everyday.